Takulandirani ku AMTV Malawi kuchimake kwa nkhani zenizeni. Ngati nkhani imeneyo kuno kulibe, dziwani kuti nkhani imeneyo ndi yabodza.
Thank you.
Good afternoon. My name is Maureen Chifundo Seolachira. I represent the people of Mwanza West constituency and I'm the vice chairperson for this committee. Thank you.
Through you, Honorable Chairperson, I am Sunge Kalumo, Parliament Secretariat.
Through you, Honorable Chairperson, I'm Endless Nyale, Parliament Secretariat.
Thank you very much. And my name is Anthony Masamba, Chairperson, Parliamentary Committee on Health. At this juncture, I would like to humbly request you, Honorable Stakeholder, to introduce yourself, please.
Thank you, Honorable Chairperson and Honorable Members. My name is Grace Tikambenji Malela, and I'm the Ombudsman. Thank you.
Thank you, Chair. I am Demo Muo, Deputy Director of Investigations and Research Ethics Section.
Good afternoon, Chair and honorable members. I'm Hawa Chatepa, Deputy Director of Legal and Advisory Services. Thank you.
Thank you, Chair. My name is Arthur Semba, Chief Investigations and Research Officer. Thank you.
Thank you, Chair. My name is Henry Gachisi, ICT Officer for the Office of Obudsman. Thank you.
Good afternoon, Chair. My name is Jamison Jauluka, Principal Civic Education Officer, Office of the Ombudsman. Thank you.
Just to add, Honorable Chairperson, that will soon be joined by our Public Relations Officer, Madam Ruth Lupanga, and my directors to register their apologies, Madam Chipidiro Mangulama, who is our Director for Legal. She's traveled to China on duty, and Madam Martha Kwengwele, who is on an annual leave. Thank you.
Thank you very much, and thank you most sincere, honorable members for availing yourself this afternoon. We have had a very good, productive day, starting with interaction with members from the media consortium on the same issues. Now that you are here, we are expecting to have you and the Pawem Patients Association Warfare of Malawi. If I get that right, I think they should be on their way. Meanwhile, I think you can proceed with your presentation as we wait for Pawem members. Thank you very much.
Thank you, Honorable Chairperson. If I may be allowed to move to where the laptop is, I think we cannot bring it any more closer than that.
Chair.
Thank you very much. Before we go into the presentation by the Ombudsman, we've been joined by the members from Pawem. Would you kindly introduce yourself, please?
Chair, point of order. Is it in order that one of our stakeholders is not putting on a jacket as per parliamentary procedure? Thank you.
Thank you very much. The people of Blantyre City South, Lonzo, your point of order is sustained. I think one of the stakeholders, as I can see, is not complying with the dress code, the parliamentary dress code. As such, I would humbly request the stakeholder to step out and come back when you have met all the necessary parliamentary dressing code. Thank you very much. We can proceed with the introductions. You can sit down, don't worry.
Good afternoon. My name is Kondwani Kucherekana, working with the Patient and Community Welfare Foundation of Malawi, Pawem, as Executive Director. Thank you.
Good afternoon. My name is Godfrey Banda. I work for Pawem as a Director of Programs. Thank you so much.
Thank you very much. I now hand over to Ombudsman to make your presentation. Thank you.
Thank you very much, Honorable Chairperson and Honorable Members. At the outset, may I seek your permission that I present while standing to enable me better project my voice. Thank you so much. Honorable Chairperson and Honorable Members, I will start my presentation by registering our profound gratitude to the committee for the invitation that was extended to us to come here and engage with the committee on an issue that is very pertinent to the country. And as we speak now, I think it is even in the public interest, because not a day goes by without any one of us seeing issues of siphoning of medical supplies from our health facilities. And I think it is reaching, I would dare say, crisis levels. You come from constituents, so you should know this better. I also have people from the village that call me all the time, and they say, we went to the hospital, but they've sent us back because they say we should go and procure Panadol on our own, penicillin on our own, and so on and so forth. And as a mother, I sit back at home and I say, I look at my pay slip and I look at the money that is being taken to sponsor those drugs. And yet they are not available in the hospitals and so on. So we take this as a show of trust in the Office of the Ombudsman that the committee has to be able to say, come and address us on what we know and what we do as an Office of the Ombudsman. We do not take this for granted. If my memory serves me right, this, I think, could be a historic moment. It may be the very first time that we are engaging with the Committee of Health in Parliament. So thank you so much. We prepared a presentation. I'll just briefly speak to it in the hope that ultimately the committee will still sit back and read through it and I think be able to proceed on what we'll have presented. We are looking at the role that the Office of the Ombudsman plays as an accountability platform for quality health service delivery. Within the context of the agenda that you had set for us in the invitation to come and address you on issues of corruption, the status of corruption in the health service, I need to place a caveat, number one, that as Office of the Ombudsman, we are not necessarily mandated to look into issues of corruption. That rests with the Anti-Corruption Bureau. But what is critical about our office is that before corruption even happens, there is unethical conduct, there is maladministration, and that sits with the Office of the Ombudsman, such that if we invest a lot in what the Ombudsman can do, then things will not escalate all the way to become corrupt practices. So we will be speaking more to that ingredient of corruption. Of course, there's a very fine line between what happens as corruption and what happens as maladministration. To put this presentation in context, I got this picture from our 2025 annual report. That is what we found in Kasungu in 2024 when we had gone to do our work. We go to communities to carry out what we call mobile accountability clinics, where we chat with ADCs and members of the general public. We tell them about our work and how they can utilize the office, and they in turn register complaints. So after we had done one search in one of the TAs in Kasungu, the members of the community were able to then recognize my administration and say, Ombudsman, zimene munena zukanga tikunoko zimachitika. Permit me if I switch to Chichewa. Thank you so much. Mukanga tizimachitika at this particular hospital, this is what has been happening. We've been observing helplessly. So we started an investigation. What was happening was an organized syndicate where almost a lot of the patients would be told, there's no medication, go to such a market, at such an order or store, you are going to find. So we worked with the police to follow through that trail, and that's just part of the consignment that was withdrawn from a private market, and the police have since investigated and prosecuted the case. Why I'm presenting this is to indicate to the committee that this may be a tip of the iceberg. We need coordinated efforts. We need a citizenry that is aware people in your constituency should be able to say, how come I'm buying this medication here at Nkando Trading Center and not at the Tuchira Healthy Facility, just to illustrate as a way of example, and be able to feed that into the system. Having said that, a quick outline of what we are going to present here. I've already talked that the Office of the Ombudsman deals with maladministration. We will not dwell this too much because we are here to present the statistics that we have. But this was to give a context to this presentation in the hope that when you sit back and you are reading, you are going to then place everything that we do within that constitutional and statutory context that we have. So I'll look at that. I'll briefly explain what our mandate is, what maladministration is, and why we focus so much on ethics. That government 5 years ago approved a functional review where we now have a standalone ethics, sectoral and ethics department in the Office of the Ombudsman. And I'll then come to the gist of this presentation. How are the statistics looking like from 2018, when what we call the Hospital Ombudsman was set up, to date, and what are those statistics telling us? Beyond that, it is our hope that then the Parliamentary Healthy Committee is going to engage with those statistics and be able, number one, to even support the work that the Ombudsman does. Number two, to inform your own further conduct, as I understand you are doing an inquiry of sorts. Very quickly, the Office of the Ombudsman is an independent institution. This is very clear and very critical. Independent of any authority. Independent and to work without fear or favor. That is why the Ombudsman is able to investigate the police. The Ombudsman is able to investigate State House. The Ombudsman is able to investigate OPC, MDAs, and come up with objective and reasoned determinations that must be complied with. The core mission is to promote administrative justice, accountability, fairness, and good governance by providing redress to persons affected by maladministration. I will illustrate this by a very simple example that I like to give. In 2023, we handled a complaint of an 18-year-old and 22-year-old woman that had not received their father's death benefits when they were 2 years and 5 years respectively. So they grew up in poverty. As we all know, you go to the village and life continues until the Ombudsman did the mobile accountability clinics and they learned of the work we do. When they came, we followed through that matter, we investigated. Unfortunately, they could only access that money much later in life when they had lost opportunities for school and everything that could have happened in between. When they were 18 and 22 respectively, Mangochi District Council, which was the errant District Council, finally processed the deaf gratuity, maybe 18 years, 20 years down the line. They got their money. I think for me, why I like to share this story is when they were receiving their checks, something occurred to me that they probably would not know what to do with the check. So I asked them, have you ever been inside of a bank, any bank? They said no. Have you ever seen a check? No. I told them, what you have now is a check. You need to take it to the bank. Do you have bank accounts? No. So I called a bank manager somewhere and told them, I'm sending you 2 ladies. I want you to assist them open accounts. And once they've opened, that money is going to be drawn at once, and so on and so forth. So these are the people that the Ombudsman serves. They come from your constituencies. But what you read in the papers is, the Ombudsman has nullified the MERA appointment of CEO. That's one of the functions. But we work with people in your constituencies to access water, to access electricity, to access medication. So that's our core mission. And I will say on the Hospital Ombudsman. The Hospital Ombudsman is one of our mechanisms to go sectoral. And I'll explain later because this is where we are drawing the statistics from. As I said, we are established by the Constitution, Section 120. Our mandate derives from the Constitution, Section 123. And the powers derive from the Constitution as well as the remedies that the Ombudsman can grant. What is the implication of this? The implication of this is that no person can wish away the Office of the Ombudsman. No person can wake up and say, Office of the Ombudsman, unless you all gather and come here and amend the Constitution, which would be contrary to the dictates of good governance and the trust that the people of Malawi have in you as the august house. How do we do our work? We investigate, like I said. We carry out inquiries. We provide determinations, we make recommendations, we also promote good administrative practices, we carry out research, and we educate in a nutshell. Honorable Chairperson, there are slides here that I'm skipping, but they'll give you the context that you need when you're discussing, where we are discussing what is administrative action, what is administrative justice. Basically, it's just avoiding bad administration. How do we avoid bad administration? By making sure that we are not making decisions that are contrary to the law, decisions that are arbitrary. So I have handled a lot of cases in the Office of the Ombudsman where arbitrary decisions have been made. A government official comes, let's say a headmaster, and just tells a teacher, without any reasons, without any documentation whatsoever. Avoid unreasonableness, avoid decisions that are without proper justification, lacking in procedural fairness. So some of the issues I've handled, the outcome will have been correct, but they will not have followed the right procedure. That is also maladministration. Or made without due consideration to the merits of the matter, or made corruptly. All this is maladministration. In a nutshell, maladministration is equal to unethical conduct. I will not. So Section 123 and Section 5 of the Ombudsman Act encapsulates what is it really that the Ombudsman should be looking at. So we look at injustice, abuse of power, unfair treatment, and all of those issues that are outlined in that slide. So why did we accept the invitation to come to the Health Committee to make our presentation? Is because, like I said in the opening, we think maladministration in corruption. If maladministration is curbed, then it won't go on to escalate and manifest itself as corruption. So here are a few examples. Delayed services at public hospitals, that is maladministration. So we have gone to public mobile accountability clinics where we have found clinical officers that will open hospitals at their will as they feel like. So this is deep in a rural area where people have gathered at a clinic. The clinic is not open because the person that is supposed to open it is taking their time, maybe drinking tea or maybe attending to their farm before they can come. That is administration. What happens if there is delay? Then we all begin to scamper for services. Then you and me, the elite, are going to say, how can I jump the queue? And we all know what happens. The dobas are going to say, madam, that is very possible for as long as you have Fanta and everything. At that point, everything is happening because somebody decided not to start the service at 7:30 exactly, and there's a pile-up of people looking for the service. So it leads to informal payments, as we have found in the Office of the Ombudsman. Abuse of authority by public officers. This is maladministration. What does it lead to? Drug theft from public health facilities, like the example that I demonstrated. Denial of services to patients without means. We have seen this through our hospital ombudsman platform. At the risk of being put on the record, but I want to illustrate this by example. In Undine, in our suits, made of Valiram, when we present at a medical facility, people come. They don't even know you are an MP, but they'll just come and say, they will literally, My grandmother, when she presents at our local hospital, barefoot and everything, at Akuswera Mpakajani, mpaka 3 o'clock. These are living realities, isn't it? So the denial of services to patients without means then make them, in some instances, to say, what is it that we can do to motivate, to incentivize this system to respond to us? And that's how they end up parting with the 5,000 kwacha, which to them may mean everything for that day. Unjust decisions by government organs that would lead to bribery to access priority services, siphoning of public resources, and then weak accountability structures. When you weaken institutions like the Office of the Ombudsman, there is going to be all manner of issues. So that's what we are seeing from the hospital ombudsman mechanism. I will illustrate by saying that from operating the hospital ombudsman mechanism that I'm going to unpack just now, 2018 to date, we have seen a 284 rise in informal payments. These are payments that are not going into the system. We are not calling them corruption, we are not calling them bribe, we are not calling them coercion, because we haven't gone to pinpoint what it is, but we know they are arising from our administration, someone wanting to cut the corners and everything. So this is coming from our data from 2019 rather, to 2026, including drug theft at public facilities, and we are having a 47.6% resolution gap, as I will explain. All this is a symptoms and manifestations of maladministration and corruption across the sector. Honorable members, there is also slides 2 or 3 that are making a linkage between ethics and hospital ombudsman, because this is why government approved that we should run the mechanism that is called the hospital ombudsman. But suffice to say, for the health committee and for us as ombudsman office, our complementary role and mandate is that we should ensure that ethics is institutionalized in our public offices. And the classical example that I give for institutionalization of ethics is ngatintima wako muntu magunda, when you're walking into a meeting that was supposed to start at 8 and you're walking in at 9. That's the basic encapsulation of ethics. Or if left alone at a traffic sign and there's red, but there's no car on either side, whether you still proceed or whether you're going to wait until the green sign comes up. That encapsulates what ethics is all about, integrity and ethics. And if we do our mandate, our joint mandate very well, we are going to help earn public trust and confidence in our institutions, including in our hospitals, save billions on lawsuits. We will make better decisions as decision makers, and there will be strategic planning and strategic thinking and improved employee performance. So those are the basic tenets of ethics that I would like to put as a context for the presentation that we are making today. What is the effect of maladministration? As I've already demonstrated, it damages the image of the institution and profession. I'm sure we all now know professions in our own country that when they are mentioned, there's all bad adjectives that are used, isn't it? So abuse of power, I've already talked about it, heavy costs, abusing confidentiality, falsifying information, and making decisions, and so on and so forth. I will now share with you the statistics as they are looking where the hospital ombudsman is concerned. But first, let me unpack what this mechanism is all about. The first clarification that I would like to make, that this mechanism, the custodian is the Ministry of Health. It is not the Office of the Ombudsman. It is under the Quality Assurance Department or unit in the Ministry of Health, headquartered in Capitol Hill. But why the hospital ombudsman is at the center of this, it is to ensure that it runs independently, number one. Number two, that it has the requisite capacity. So when the Ministry of Health identifies who amongst its staff are going to be designated as hospital ombudsmen, then the ombudsman comes in to train them. We go to monitor their activities, we give them the capacity, and we also then work with them to ensure that they are working independently. I'll come to the issue of does that guarantee independence of that facility if it is sitting within the same Ministry of Health. We came up with this, which is a hybrid model, because in other countries, parliamentarians like yourselves would have enacted an act of parliament establishing a hospital ombudsman as a standalone, and you'd have been entrusted with the job of hiring a hospital ombudsman, just like the ombudsman is hired by the Public Appointments Committee, and making sure that DHRMD gives it to the staff. When this was coming, the argument then was there's no longer financial capacity by government to be setting up new establishments. So for example, the Human Rights Commission ended up anchoring the Gender Equality Commission and the Information Commission. The hospital ombudsman ended up anchoring the ombudsman ended up anchoring the hospital ombudsman. Is it working? I will illustrate also by figures. Does it have inherent challenges? I'll also explain. So it was established in 2018, grounded in the mandate that the Ombudsman has to ensure that we are facilitating and building complaint handling capacities within government organs. Who does it serve? All patients, caregivers, and hospital users at public health facilities. And here I must mention that it should also be able to serve you, honorable members, There are several issues you are handling, in constituency 1, regarding the hospitals. Look out for the hospital ombudsman in that health facility and make them serve the issues that you have. But more in particular, it serves the vulnerable, people that are not able to have a voice and speak for themselves. Just like the ombudsman, it has the same functions. It receives and investigates cases. Those small, minor cases, it resolves on the spot. The ombudsmen are able to resolve on the spot. In Nkota the other day, there was a gentleman that went to the hospital. And when he went to receive mankwala pa pharmacy, the pharmacist says to him, "We do not have that medicine." Yet the person that was in front of him received the same type of medicine. So it got him wondering and thinking, and he went to the hospital ombudsman to say, "There's this." The hospital ombudsman went and actually found that that particular drug was there. I think it was just the choice by the particular pharmacist. The gentleman in a barefoot and so on. Sometimes you can be discriminated with your own system. So he was able to get that kind of medication. They also mediate on issues. For the complex issues, they escalate to us or to medical council or to an appropriate authority. So for example, in Inchinji, there was a case where the medical professional there was sexually abusing a particular woman when she was going for antenatal services. Obviously, that was not an issue for that local ombudsman to deal with. It was escalated into the system. We facilitated working with the police for prosecution and everything, and the matter was taken up in that manner. They conduct civic awareness, particularly on health service charters and citizen charters. They carry out referrals and escalation like I've taken, but more importantly, they gather the data that I'm going to present to the committee this afternoon, and then they give back feedback to authorities. So I'm sorry, because I think at the furthest end, you may not be able to read the presentation. We had thought it was those projectors that we didn't think it was going to be a screen. But what the statistics are telling us, when this platform was first launched in 2019, it was able to record about 228 cases. Since that year, the cases have been increasing, as we are seeing, to 5,000 or 6,000 in 2021-2022. Then a jump to 12,000, then a jump to 15,000, then a drop to 10,000 cases. And then now, as we are extracting the data for purposes of this presentation, the complaints are standing at 22,775. What I say when people say dismiss the hospital ombudsman mechanism to say they are not convinced of its utility, my answer is we need to put the faces behind these figures. What this means is that were it not for the hospital ombudsman platform, probably these 22,000 people, assuming it's individuals, not groups, would not have had their grievances resolved, would not have access to justice and a proper service within the justice sector. I need to clarify that in one of these, in the 2024, what was recorded there was in 2029-2020, the spike there was an anomaly, and the data set was recalculated thereafter. So we now have a corrected version. Suffice to highlight that from the point of its inception to date, people are becoming increasingly aware of the availability of this platform, and the cases that are being registered within this platform continue to increase. When we're studying issues around the sexual reproductive health, which is my area of specialization, which I would like to extrapolate to this, is that, does this mean mavuto wa akuchulukira chulukira? Not necessarily. The problems are there, and if we don't do anything, are going to continue to be there. What this means is that the mechanism for getting people to complain is now available and increasingly becoming aware. So that is why perhaps we are seeing this kind of increase. There's also a widening gap between the cases that are fed into the system and what we are actually able to resolve, and this is because of capacity issues that I'm going to speak to. The dramatic drop in 2025-2026 reflects the surge in incoming complaints outpacing capacity. We target a resolution rate of 80%, and this is what we need support for us to be able to deal with the complaints. I also suffice to mention that in 2022-2023, there was a low rate of 43% that coincided with the post-COVID demand surge and staffing constraints. I will now go to the departments, Honorable Chairperson, that where most of the complaints are registered, and the type of complaints, and the estimated percentages. So you have nursing and nursing ward and wards, Kumawadi, where the types of complaints would be neglect, rudeness, and delays. Again, off the record, we encounter these delays, particularly in our maternity wards. So I've been privileged to be in that place 3 times, and I know what these patients complain about in the maternity ward. So it's standing at 32%. OPD and outpatients, the complaints usually are around long waits and the denial of service, standing at 24% of all the complaints that we are in the system right now. Maternity and labor wards, negligence and informal payments. I think this needs to be noted. It's standing at 18%. Pharmacy, drug shortages and poor dispensing of the drugs, standing at 12%. Laboratory services, delays and lost results. So you go back, they say, we need to draw your blood again because we can't trace your results in the system. 8%, and administration related, so discrimination and billing issues standing at 6%. Honorable Chairperson, it has to be emphasized that this is the data, maybe negligible. I think other regulatory mechanisms for our hospitals would be able to provide much more data. I don't know what the ACB would also be able to provide. But because you are policy makers and you need to make evidence-driven decisions, this is a starting point. Why I'm calling it a starting point is because your office, the Ombudsman, can take this mandate further if it is properly capacitated to actually carry out an entire systemic investigations into these issues, like we have done on AIP, like we did on COVID, like we did on other health-related services, to establish the magnitude of this problem and to be able to say where do we really need to inject resources and ubangiri, so that I think this story needs to start changing. What is obtaining out there, at the risk of profiling my own personal opinion, is quite sad. So informal payments reports have risen to 284% since 2019, and we're at 242 in 2025-2026. We are emphasizing on informal payments because this is can be bribery, it can be corruption, it can be other issues relating to corruption. The sharp increase of all these statistics, like I'm saying, is suggesting growing awareness. People always ask me, are people aware of the hospital ombudsman mechanism? I don't know, it could be that you're also hearing it for the first time, or you had your own skepticism around the hospital ombudsman mechanism, but this is the work that we are trying to do. On informal payments, we are also cognizant of the fact that there is now an executive order of February 2026. We would like the committee really to look into that executive order that looks at the issue of our personnel in the hospitals running their own private entities, the conflict of interest, and sometimes how we have read in the papers, this has not come through the platform, that a service that you can obtain at KCH, then they'll tell you, but you can best get it at such and such, at this fee. Those issues need to be looked into. So in a nutshell, informal payments in public hospitals are standing at 242 complaints out of the entire data set. Out of the 2025 data, this is 1.5%. The typical informal payments would range from 500 kwacha to 5,000 kwacha. But I think the question that I posed earlier is, what does 5,000 kwacha mean to that ordinary member in your constituency? Patients report being instructed to place cash inside healthy passports. This we have collected from the data set. Those unable to pay are ignored or received delayed care. Maternity and emergency wards are disproportionately affected. Patients are sick, desperate, and unable to refuse the payment when all you want is for a certain ailment to leave your body. I think you are going to try your best to bring that 5,000 kwacha. Hospital ombudsmen are employed by MOH, like I said. we have received constructive criticism that how can they carry out effective investigations and monitoring if they are employed by the very same system that they are supposed to monitor and investigate. So a typical scenario, for example, would be a senior HSA at a hospital receiving a complaint against the medical or clinical officer there. It's a mixed bag. Those that we have trained and really understand their mandate are able to escalate those issues up into the system to our office. There's human element. We cannot take away the subjectivity that maybe a little bit of independence there is also impinged. And this is where when you see what we are recommending, there's been a school of thought that can we make the hospital ombudsman mechanism independent. But the question that a policy-making body like yourselves would have to address is, how would that independence look like? Does Malawi have the capacity to establish a health ombudsman, for example, like they obtained in South Africa? In South Africa, there's a health ombudsman, tax ombudsman, military ombudsman, over and above the general ombudsman. We also saw reporting of numbers in the informal payments. Because it takes two to tango, it's very difficult to get your statistics correct on who is making informal payments, who is corrupting the system. Because number one, people want to get rid of their ailments. So, no matter how much sensitization we do, people will say, for as long as I'm fine, I'm not going to report, number one. Number two, for fear of reprisals, and so on and so forth. So there are all kinds of factors that are affecting underreporting. We are of the view that the fear of retaliation and distrust in the system affects the numbers that get reported through the hospital. How do we carry out the work? Some of the work that we have done on hospitals. In 2024, we conducted preliminary investigative research into allegations of informal payments at Queen Elizabeth Central Hospital. This information will be provided to inform the committee's further work. I think the findings and allegations are the ones that I've already looked into. I already cited the example of the case in Chisikwa, ADC in Kasungu, that was reported through a mobile accountability clinics and the drugs that were traced. The outcome and impact, illegal drugs were confiscated, the suspects were arrested and taken to police for interrogation, criminal investigations and prosecution commenced. So having looked at the statistics, Honorable Chairperson and Honorable Members, I would like to just briefly share what we have noted as challenges in implementing the hospital ombudsman. Lack of independence, as I've already said, people cite this as one of the impeding factors, underreporting and fear, structural hierarchy, staff shortages and capacity. So we train the hospital ombudsman once they've been designated. After 4 years, you find that their employer has transferred them to a different hospital altogether, or they've been promoted and they can no longer perform the role of a hospital ombudsman, and low resolution rate of cases because we ourselves are also not adequately funded. Right now, of the 14,897, the resolution rate is at 47.6%. I have put in the slides a model of the South African Health Ombudsman for your own information. What are we recommending? We know we came here to share with you what we have as the status of corruption, stroke maladministration in our healthy facilities. But because this is a rare opportunity, we thought when we have shared, you might want to sit back and say, how can we strengthen the role of the ombudsman? How can we strengthen the hospital ombudsman mechanism? Number one is to strengthen its independence. Right now, last year, we worked with the Ministry of Health to develop a strategic plan for the hospital ombudsman. And I think the most immediate things that need to be done, even as it is sitting within the Ministry of Health, is to give it a dedicated budget, which it doesn't have at the moment. So what happens is, today World Bank gave us this money, and World Bank is saying, Zotaras will see what you can do. Ombudsman, where are you? We have found this little money. Action Aid comes up because of their program. They're doing monitoring of health. Ombudsman, where are you? Can you work with us on this? So there's no dedicated budget within the Ministry of Health, if that can be. But in the long term, issues of setting up, I think there's clear evidence that our health facilities could use the services of an independent health ombudsman. Expand staffing and coverage. Ministry of Health should be supported to recruit and actually train dedicated hospital ombudsman, not the system as it is now, where an assistant human resource management officer is designated over and above HR, you are also hospital ombudsman, or an HSA is designated to say over and above. Increase the budget allocation, like I've said, ring fence and dedicated funding to the hospital ombudsman. This means increasing the budget that goes to the Ministry of Health and also to the ombudsman so that we can complement each other effectively. Community empowerment, please support us to be able to carry as much mobile accountability clinics as we can do, but also the partners that are here, the colleagues from the patient's body, and also Malawi Health Equity Network and others that we can partner. But right now we can't even begin to partner with them because they're asking us, what are you bringing on the table? Are you going to take us to Zomba? And we say to them, we actually thought in Yonda Memory in Drama, if you capacity, and at that point, the story ends there. Tackle informal payments. If there is a priority area that your committee might want really to weigh in, is the issue of informal payments. Our people are suffering. And I've already stated, I can't emphasize the point anymore of what this 5,000 kwacha means. I don't know about you, honorable members, but even to me, 5,000 kwacha today, I'm thinking twice before I can give it to my daughter. I think things have come to that point. And then improving data quality. As we noted, at some point, this data needed recapitulating and so on. So the DHIS2 complaint tracking needs to be improved, and everything that goes with that, so that it can inform evidence-based policy reforms. And at that juncture, I'm really looking at honorable members as Honorable Dr. Mpunga, because I think he invested a lot of his career in this. Sitting on the other end, what do we do? Because I think all the members here do not need to be told about the problems with this system, but to acknowledge it and to say, including yourself, Honorable Chairperson, what is it that we need to do to have credible data, and data that can inform us in budget allocations and data-driven decision-making, as it were. So my next slide is basically this one, which says thank you for your kind attention. And then I go back to this one, which is just a synopsis of the work, even though some of this is not part of the presentation that we are making here, but just to say, when you ask, what is our Office of the Ombudsman doing, kuyambira January mpaka December, I think this would be the kind of snapshot of the work that we do. I'll pause for a moment, Honorable Chairperson, to ask colleagues if I have left any salient material to be presented. No? It's okay. With that, I come to the end of my presentation. Thank you so much, Honorable Chairperson, honorable members, for your kind attention. Thank you.
Thank you very much, Madam Ombudsman, for that elaborate presentation, quite insightful. You have energized us as a committee, but also as members of parliament, but also people who are coming from the community. We serve the same people that you are serving. And with that, with revelations coming from the Office of Ombudsman, I think we have something to start with. We go to the Pawem, your presentation. If you can just focus on the pressure points, 10 minutes. Right.
Thank you, Honorable Chairperson, and all the honorable members present, our fellow invited organizations, and all the present members. My name is Godfrey Banda. I'm working for Pawem as a Director of Programs, and my responsibility this hour is to present to this parliamentary committee on behalf of Pawem. We are a patient and community. We are
yes,
a patient.
There's point of order. Can you switch off your mic?
The people of Chiripa South through chair can hardly hear the person. If you can raise up his voice.
Thank you very much. You can come closer to the mic, and if you can speak up, please.
Thank you, Honorable Chair. I hope I'm audible enough. And all the honorable members, as I said earlier, my name is Godfrey Banda. I'm coming from Pawem. Pawem is an abbreviation that stands for Patient and Community Welfare Foundation of Malawi. We are a local organization working with patients in the communities, and I want to thank the chair and the committee for inviting us as a Patient and Community Welfare Foundation, whereby we feel like this is an honor to hear the real examples and the real impacts of community health in relation to corruption. And also you'll hear more from us, especially to the community that we serve. We normally deal with people with lived experiences. Thank you. So my presentation, that's my presentation outline. I'll go through the introduction and background, why the inquiry matters, major forms of corruption that we see in the community. I believe these are the communities that the honorable members also serve. The drug theft and procurement scandals that as a community we have heard, we have seen, and also case studies from public hospitals, impacts on patients and health systems, root cause and system weaknesses, and some oversight and accountability challenges. In addition to that, I will also go through international lessons and best practices and recommendations and conclusion. So we all know that corruption threatens healthcare delivery, and it's something that can affect national development in the sub-Saharan Africa. At the same time, we also know that billions of kwacha are lost annually through fraud, abuse, misappropriation of funds, and we all know that it's a reality that there is drug shortages in public hospitals that are directly affecting patients that we also serve as a patient and community welfare foundation of Malawi. We also know that corruption weakens donor confidence and emergency response system as a country. Just a snapshot from the literature review annually, that was from 2024, 2025, there was an operation of, out of the $230 million US, the literature says that 20 to 30% is estimated loss due to corruption here in Malawi. And if you look at this, the under 5 mortality rate is currently at 69 per 1,000 women here in Malawi. So why this is a crisis to both honorable members, the communities that we serve, local organizations like us, and I would like to take this opportunity to thank this committee for including local organizations like us, because we will provide real evidence data, experiences, and also what the communities out there are expecting from us. So I don't take it for granted. We really appreciate as a local organization. Why this inquiry is important to us as a patient and community welfare foundation and all of us here. As I said, we are an organization that serves people or communities with lived experiences. These are people that are the end users of the health services, whether through medicine, either through any public health issue in our communities. So this inquiry is very, very important to us because it includes issues that are alarming outside there. For example, medicine shortages. We all know that our health facilities are much more involved in corruption issues that are affecting the availability of medicine in our public health facilities. And if you look at this, it has got a bigger impact to the users because they have got no option than using out of pocket, whereby it gives maybe 3 or 5 times the actual price of the medicine that they are supposed to get from the public hospitals. This inquiry it's also important to us because it gives an insight on how resources are being diverted. And also, it gives an insight on how corruption is directly affecting preventable death. So in this case, annually, over 12 million people in sub-Saharan Africa, they lose their life because of these preventable deaths. Suppose your mother, my mother, goes to a public facility to say she has been diagnosed of malaria and she's told that there is no malaria drug. Obviously, we expect to lose that woman. These are preventable deaths, as an example, because if this woman did find the medicine at the public hospital, obviously the treatment could have been there. This inquiry is also giving us a threat on the universal health coverage. We all know that as a health, we are aiming at achieving the universal health coverage. And as I'm speaking right now, the Malawi Universal Health Coverage Index is at 46 out of 100, which is even below the standard in the sub-Saharan Africa of 53%. The inquiry is very important because the insights that Honorable Chair you will get from us here, from all of us, it will also give you donor confidence. Because, for example, as I said, you have engaged the users. We actually work with patients and communities that are the users of the health services. So this, I believe, it will give donor confidence, considering that the policies, the ideas, the new, whatever we are going interventions to make from this committee meeting, they will actually bear the insights of the users who are the local marginalized communities in Malawi. So in Malawi, as a health sector, I came up with an analysis of a few data, and I came up with these major forms of corruption in the health sector. So the leading form is falling on the medicine and supply, which is accounting to 35%. Another one is procurement fraud, which is accounting to 28%. Ghost workers and payroll in the health system is accounting to 18%. And at the same time, donor fund diversion is accounting to 12%, and unofficial payments is accounting to 7%. We know 30% of the medicine annually, they are being lost through theft in our public hospitals. And from the recent case studies that I would also share with you, most of the facilities affected by this is KCH, Queens, Zomba Central Hospital, Mzuzu Central Hospital, Lower District Hospital, and in all the other 28 districts in all the regions. And if you look at the method of theft deeply, you will see that it's through manual stock systems being exploited. At the same time, fake GRNs, and also after hours removal and collusion from our pharmacies. I'm presenting this to you, Honorable Chair and Honorable Members, based on what we see as community and patients. And I must repeat this, that we really appreciate for engaging the service users, who are the patients and the communities. And if you look at where do these drugs go, from the preliminary data, you understand that most of these stolen drugs are sold in private clinics, vendors, and cross borders, particularly Mozambique, Zambia, and Tanzania. How does this enlighten our system vulnerability? As you look at the data, we have got a very weak manual inventory And at the same time, we don't have, or we have got very few CCTV. We even allow single person access. Even our health department, there are very infrequent audits yearly. Who will actually bear this? If you look at my presentation on this, the community we are serving, the patients, are the ones to suffer from this. That's why they experience stockouts of ARVs, insulin, antibiotics, vaccines, of which these are things that are life-threatening consequences. I'll go through some few case studies that have just recently happened. We all know that in January 2026, we had a Zomba Central case whereby suspicious medicine shortages were flagged by ward nurses and clinicians. The same year in February, the internal pharmacy audit reveals discrepancies between deliveries and stock. In March, 2 senior pharmacists placed under investigation by hospital management after the whistleblowers. In April, police searched homes, and fortunately enough, they recovered insulin, antibiotics, inhalers, and tablets that belonged to the patients. In this case, these drugs, they did not reach to the service users, who are the patients and the communities. And in May 2026, the suspects were arrested, and the case was referred to SCB. I believe they have got this case. Another case, it's about the insulin scandal, whereby a clinician observed that the labels of insulin vials during routine ward rounds, they were showing that they were replaced by an old expired label. And this also gave an alarm to the communities, especially to us here. Like, why do we even allow an expired drug to be resupplied in our hospitals? And the sad thing is that these drugs, they were even distributed, the expired insulin was even distributed to major hospitals, which is Queens, and at the same time, KCH. So I'll also give you another case study from Lower District Hospital and Kamuzu Central Hospital. At Lower District Hospital, some clinicians were caught removing medicines from the drugstore after hours. And this is how weak our system is. It should give us an alarm that a clinician at a facility can just go to the drugstore, get drugs, and then take the drugs to a private clinic, just like that. And imagine a single person accessing the whole process of getting the drugs from the drugstore. It took the pharmacy assistant who raised an alarm as a whistleblower to notice that something else is happening fishy, because there was no dual authorization requirement whereby a clinician who is happened to be in charge of the facility can have the authority to open the drugstore, take whatever that he wants to wherever that he can find the market. The same similar case also happened at Kamuzu Central Hospital, whereby a hospital worker intercepted leaving premises with stolen supplies in a bag. And lucky enough, the security staff who was available on duty that particular day noted the suspicious movements of this hospital worker. And after checking the bag, they found that there were syringes, urinal bags, medical gloves. And if you look at this, where is the gap? We have a weak access control to medical supply rooms. And at the same time, this gave us an opportunity to understand how weak we are in regulation of this. As in general, we understand as a country, we are also facing procurement challenges, which are also exacerbating the corruption mechanism and scale. If you look at the quotations, some of them, they are inflated, they are able to pass through. There is an opportunity to have a single source without case. Even people with conflict of interest are still supplying medical supplies in our system. If you go through
5 minutes, 5 more minutes to go.
If you go through our emergency procurement, you will see that it's totally abused. Just a snapshot, over 4 billion it's being lost through theft, and much of these cases are affecting our health service delivery. What is the impact of my presentation on patients? Patients are now being forced to use out of pocket. We have got delayed surgeries, and at the same time, loss of public trust. What is the root cause of corruption in Malawi? We have got governance, systems, oversight, and cultural factors. And these are the 4 major root causes that we have identified. On governance, lack of political will. We feel like if the political take a leadership role, a gear in this, we feel as users, as a representation of the users of health services in Malawi, this corruption in the health sector can easily reduce. We cannot end it in a day or 2 days, but with political will, the communities there, they feel that politics play an important role in managing or dealing with corruption. And we believe that, Honorable Chair and Honorable Members, you will take this serious. Oversight. We expect that SCB should be well-resourced. You hear cases every day, now and then. But if you look at the capacity of SCB, they will say that we have got very few resources. How do you expect to handle the cases if they have got very few resources? On culture, right now, people, they have just normalized that there is petty corruption. And at the same time, giving a whistleblower because of our act, it's hard. People are normally afraid to give a whistleblower because these stolen drugs, they are mostly sold within. What if we empower the communities that the moment you observe this, report to this? I feel like we can take a good approach. So that's on weakness and oversight and accountability. I mentioned about political interference, underfunded SCB, fragmented coordination, and slow prosecutions. On average in Malawi, it takes 4 to 7 years to handle these cases. So, lessons from outside, our friends in Rwanda, Botswana, Estonia, Georgia, they have managed to get better on these health corruption cases. What are they doing? My presentation will actually be shared. I hope it has already been shared. We can also go through what are these countries doing. Recommendations for the parliament. We have got 2 agents. We believe that if we mandate e-procurement, we will actually minimize the corruption in our health sector. And another agent issue is to the parliament. Our plea is, let's please digitize the medicine tracking. It's simple and easy. Why are we failing to implement things that they have worked in other countries, even our neighbors? Please, as a parliament, we expect on this. All right, so my next slide, it was a closure slide. Thank you very much for giving me this opportunity. Thank you.
Thank you very much, Pawem and the Ombudsman, for that wonderful presentation, quite insightful again. So the platform for investigative journalism, Zodiac Nation Publications Limited and Times Group were here this morning. They made a presentation, very insightful presentation, where they brought to the fore the corrupt practices happening in the health facilities. You are an organization that stands for the patients. You work with the patients and the communities. You advocate and promote the rights of the patients. I believe when the members start engaging with you, you'll be able to explain, not now, I'll give you, you can switch off your mic, please. The honorable members who ask questions regarding your mic is still on, regarding the issues that took place in the corruption that is taking place in health facilities. Thank you very much for the recommendation that we need to embark on e-procurement and, of course, digitizing the medicine tracking. Honourable members, time for plenary questions, comments, and observations. Yes, we start with Blantyre Blantyre City South Runzu, and then we go to Cholo Konjeni Magunda, and then we go to Mwanza West. From Mwanza West, and indicate whether the question is going to Pawem or Ombudsman, and then we go to Kotagota and Kura in that order, please.
Thank you, Chair. My questions will go to Madam Ombudsman. I was following...
Blantyre City South, you have one question for this round. Thank you. You have one question for this round. Thank you very much.
Thank you. I was listening to your presentation, and I noted that you were talking about the independence of the Ombudsman officers in the health centers and the hospitals. And I do understand that it's not feasible for us to hire almost 1,000, individual ombudsmans in the district hospitals. Have we perhaps considered maybe partnerships with, CSOs and other institutions, and so that we could be able to do that? And also, I think you said the ombudsmans that we have now are hired by the Ministry of Health. And in your recommendations, you also spoke about maybe having the ombudsman's payroll in the Ministry of Health. Maybe if we could also consider having a different institution hire these people instead of the Ministry of Health, as the independence there is a bit of, sketchy. Thank you very much, Chair.
The people of Blantyre City South Runzu for that question, partnership, or can we consider if we want to promote independence of the Office of Hospital Ombudsman, having them employed by independent organization? We go to the people of Cholo Konjeni Magunda. Thank you.
Thank you, Chair.
You also have one question?
Thank you, Chair, for yielding the floor to the people of Konjeni Magunda constituency. I've got two questions. One,
for this round, you have one question, please.
Okay,
stick to one.
My question goes to the Ombudsman. Recently, we saw an article that says pay up or die, whereby the PHI had investigated about what is happening in some of the hospitals in Malawi. And even the president himself, after seeing this investigation article, had executed two orders. How far have we gone with the office in investigating this issue? Thank you.
Thank you very much. Straightforward question to the Office Ombudsman. We go to Nchinji Southwest.
Thank you very much, Honorable Chair, and through you, let me thank all the presenters for the job well done. But my question, straightforward, will go to Pawem. Pawem, I'm very happy at the end of your presentation, you have recommended for e-procurement, but also perhaps hospital digitalization. But specifically, these are just going to the government in general. But I would want to zero in on us as your parliament regarding the issues of accountability, mechanisms, and trust. From your findings, what are the accountability mechanisms and that exist in the hospitals? We have the maybe bigger hospitals where we have the boards, but also district hospitals in our rural setup, but indeed even to the health centers. What is it that you would want us as members of parliament? Should we have maybe audits are done, as you already alluded to, but most of the times, most often they're easily ignored. What is it that you would want parliament or parliamentarians to push for you? Do you want us to push for perhaps a legislation, some sanctions specifically to punish those those offenders? For instance, we already have the Health Service Commission, but from the look of things, it doesn't have the teeth. But it's high time. This is an energetic committee, as you can see for yourself, we can come up with something that would perhaps bite for the benefit of Malawians. So we want it to come from you as an action point to us as your members of parliament. I submit, Honorable Chair.
Thank you very much. The people of Unchinji Southwest, we go to the people of Mwanza West. You have a question?
Thank you so much, Chair, and thank you so much for the nice presentations. My question goes to the Office of the Ombudsman. In your presentation, when you were talking of the challenges that you encounter, you mentioned of underreporting and fear. And when Pawem was reporting, when presenting, he mentioned of the Zomba case. And from the reports, we hear that the nurses there were afraid of victimization when it comes to reporting. So my question is, where do you think the Protected Disclosure Act is falling short, and how best can we do, what inputs can we put in to strengthen it so that there is enough disclosure, and also that people are not afraid to report these cases? Thank you.
Thank you very much. The people of Mwanza West, we conclude this round with a question coming from the people of Nkota Nkula.
Thank you so much, Chair. Good afternoon, everyone in here. My question is also coming from the presentation. I mean, the document PIJ that they produced recently. They talked about, especially in the hospitals like KCH and Queen Elizabeth, where people were told to pay for the services that were meant to be free. Amounts from ranging from 4,000 to somewhere around 260,000 for the services that were not meant not to be paid for. I just wanted to find out, Pawem, for you being a representative of the patients, did you make any strides to dive deep into it and find out the realism of the thing, like going to on the ground, finding out if this was really true, and if yes, how far did you take it to? Did you go to the police or ACB or any regulators just to make sure that the people that you are representing are really represented? Thank you so much.
Thank you very much. That's for you, Pawem. How much effort did you put in just to make a follow-up on the investigation carried out by the consortium of media organizations? Did you try to dig deeper just to complement what the PIJ and others had come up with? You have the floor, Ombudsman, before Pawem comes in.
Thank you, Honorable Chairperson, and through you, thanks to the constructive feedback that we are receiving from members of Parliament, from the honorable members here, addressing the first issue that came up from Blantyre City South Lunzu regarding the independence of this that we are putting, the personnel that are designated as hospital ombudsmen, and perhaps trying to latch on to partnerships so that we are able to absorb the burden that comes with capacitating and recruiting the rightful persons. So I think again it would attract a mixed bag of sorts. Number one, we have tried out partnerships, as I indicated in the meeting, but that's for, in the presentation, for operations. So we've had ActionAid come through, the World Bank through the ministry come through for training. We can go back to the office and tease out whether we would want to extend that approach for purposes of hiring people. Because remember, we must safeguard our independence. So the day it may come out that, look, all the hospital ombudsmen that are there by the Ministry of Health and Ombudsman Office are actually paid by ActionAid Malawi. I think it would begin to cloud the independence in the event that at some point stakeholders have issues with ActionAid Malawi. They would say, what did you expect? After all, they're the ones that are paying. So for payroll issues, really, this would have to get the support of government through consistent dedicated budget that Parliament has to allocate. For operations, as we all know here, you can have donor support to help you with a number of activities. But to have donor support some of those, I do know, for example, in the Ministry of Health is there, but it's through a very elaborate arrangement, swap and everything. So we take back the feedback, Honorable Blantyre City South. We'll continue to think through it, particularly liaise with the policyholder, Ministry of Health, and see. There was also the issue of the pay up or die investigation that was raised by Cholo Konjeni Makunda, honorable member, that after we were engaged in the PIJ investigation, not necessarily this particular matter, but the position of the Office of the Ombudsman as communicated to that investigation by PIJ is that yes, we have a mandate to carry out investigations in the public sector, and the health sector is not spared. As at the time of that investigation, we indicated to them that we had carried out several day-to-day investigations pertaining to the health sector, but primarily 2 systemic investigations, one on the status of mental health services in the country, reported in our report called Out of Sight, Out of Mind, which is with the line ministry, and another one relating to hysterectomies that were being carried out, unnecessary ones, at the Queen Elizabeth Central Hospital, that is captured in a report called Woos of the Womb. So, in the PIJ response, we said, we do have the mandate and the capacity, but except the financing, because it takes a lot to invest in a systemic investigation. So once we secure the necessary resources, we can take up a very comprehensive investigations in relation to issues of accountability, transparency, responsiveness, and the efficiency and effectiveness in the public health sector service delivery. So that's where we are at. Have we moved? We are still in conceptualization stage. We are still in resource mobilization stage. And also because right now we are carrying out 2 major systemic investigations on immigration services as well as the mining sector. So all of that has got to be brought into the balance. I think the final one from honorable members for Mwanza West is pertaining to this issue of underreporting. It is really, it is true. If I'm to illustrate by a very practical day-to-day example, when you have a patient in the hospital, and sometimes you note that they are being mishandled, even our levels, we let certain things go, provided they are receiving the treatment, because if you raise an alarm, who knows where reprisals might come from, and your patient is going to be ignored. So what more with the employees that may want to report on some of these things against the powers that be in those settings? So speaking from the Ombudsman's perspective, there is a critical gaps when it comes to issues of whistleblower protection, like our counterparts have said. Right now, to my knowledge, the Law Commission was developing a complete whistleblower protection law. I'm not quite sure how far they've gone, whether it is sitting with the Law Commission or the Ministry of Justice, but they did validations for that law. If Parliament was to be implored into what else does Malawi need, is that comprehensive whistleblower protection. It may be of interest to the committee to look at where it is in the system and to already begin to raise an appetite for passing of that bill when it comes, so that every nurse, every junior officer who sees things in the healthy facilities but want to report for fear of reprisals will know that there's protection out there in the form of that law, in addition to the existing mechanisms that are there. Honorable Chairperson, I thought those were the 3 issues that I could speak to. Thank you so much.
Thank you very much. Pawem.
Thank you, Honorable Chair. The first question, it was about what are the critical laws that we want the Parliament to do to us, to make sure that we really feel that the Parliament is really taking a role in fighting the corruption. The first one is, we would love that as Parliament, they should invoke powers to summon principal secretaries, chief medical officers, and hospital directors for public accountability hearings, and make the proceedings publicly available. The other one is what the Ombudsman, they have just mentioned, we expect some legislative reforms. For example, whistleblower protection, and also amendment of the Procurement Act to mandate e-procurement, because it comes from the, it comes from the Act. So we would love that as a Parliament, there has to be a mandate to the e-procurement from the Act. And another one is that as Parliament Committee, we would love if you can have some oversight visits into the facilities anonymously. These, they will give arms to the directors, their chores, because it's very rare to see the Parliamentary Committee maybe visiting. But if these visits, they are frequent, they will give an oversight to the communities, to the facilities, that the Parliamentary Ethics Committee is really serious on this matter. Another one is to enforce sanctions. I would love if the Parliament could depermit all corrupt suppliers from government contracts and fast-track prosecutions and make it publicly available. All corrupt suppliers, they should be depermitted from government contracts. And I believe that as a Parliamentary Ethics Committee, you have got authority to facilitate that. The last one is to make sure that there is value for money assessment. I believe that as a commission, there is need of an independent commission that can be able to assess the value for money, especially in the procurement department. Some of the drugs or some of the materials procured in our health facilities, they end up just being expired. So we believe that as a Parliament Committee, there is a need for an independent commission that will be entitled to do the value for money assessments. Thank you so much. The last question is coming from Honorable from Nkotagota. What have we done on the case of Queens? As a Patient and Community Welfare Foundation, we have just gathered information, but as of right now, we cannot share the progress because we have just engaged the facilities and the patients to make sure that we provide real data. So we really come out after doing thorough investigation in whatever that we do. Thank you so much.
Thank you very much. The Ombudsman wants to compliment the Pawem.
Thank you, Honorable Chairperson. I thought as a public officer, it would be remiss of me if I didn't provide a little bit of clarity on e-procurement, that actually the necessary amendments were made. The relevant authority, the PPTA, has since rolled out the e-procurement. As we are speaking, I think a lot of us public institutions have since registered on the MANEPS system, which is a platform. So every institution that's not on that system is no longer going to procure until you register on that system. Maybe then we could be looking at Parliament overseeing the rolling out of that system, ensuring that it is fully funded so that maybe we can prevent the teething issues it may have. But it's there, it's up and running. And we are an example of an institution that has just registered on that system in the past weeks. Thank you.
Thank you very much. Quite true. The e-procurement system is up and running. And I thought honorable members would be, well, I know some of these members are also into business and they know that this system is up and running. But we continue with questions. We start with Chitipa South, then we go to Mangoji West. Chitipa South, you have one question. Then we go to Doa Mpudzo, one question. We go to Nzimbaperekezi, a question. And then we finish off with Nchewu, the wise people of Nchewu North. In that order, please. A question each.
Thank you so much, Honorable Chairperson, for granting the people of Chitipa South a chance to ask a question to the Ombudsman. Honorable Chairperson, in her presentation, she did cite a case of Nkhotakota District Hospital, where a pharmacist denied a patient or a client of the medicines which were available in the pharmacy. Suffice to say that this issue was reported by the hospital ombudsperson to your office. This is Parliament, and Parliament is a political house. Given the fact that outside there, people complain of drug shortages, and it's a political issue already on its own. And then this is a case where the medicines are available in the pharmacy, and the pharmacist decides not to dispense the medicines. The matter is reported to your office. I wanted to hear from your office, what exactly did you do to this particular practitioner? Chair, I submit.
Thank you very much. Doa Mpudzu.
Thank you, Chair. My question is looking at the ordinary person in the village. How can someone in a rural area who can't come to Blantyre, who can't come to Lilongwe?
The people of Doa Mpudzu, where is it the question being directed to? Right, Ombudsman.
So I wanted to know, especially for a person, an ordinary person, let's say from Doa Mpudzu, from my village, if he goes to the hospital, then he's not in Blantyre, he's not in Lilongwe, how does he reach your office? Is there a provision for a WhatsApp, or is there a provision for any other access that may help someone reach your offices? Finally, I wanted also just to find out, I've seen on this, the model talking about the reporting that you report to the Ministry of Health. I was just thinking loud, how do you report to your own boss who you're investigating? Is that not something, is not something that will create some lapses on the way you deal with the issues? Thank you.
Thank you very much. Conflict of interest there. How do you report to the same boss that you're investigating, and the reporting mechanisms from the village up to the office of Ombudsman? We go to the people of Nzimba Perekezi.
Thank you, Chair. My question goes to the office of the Ombudsman. I just want to know, how does your office coordinate with the other stakeholders like ACB, National Audit Office, or other CSOs to make sure that each and every complaint is investigated? And also, may you please cite some examples where such coordination has made fruitful investigations, and also in some instances where it has failed? Thank you.
Thank you very much. We go to the people of Nsheu North.
Thank you, Chair, for recognizing the wise people of Nsheu North. And through their wisdom, allow me to ask a simple question to the Ombudsman. The PIJ investigation documented ambrose extortion at Likoma and mortuary fees at Chiladzulu Hospital. Did your office receive any complaints on these specific practices? And if indeed you received any, did you refer those cases to the ACB or the police? Thank you, Chair.
Thank you very much. The wise people of Nsheu North. We go to Zomba City South.
Thank you so much, Chair. When the Ombudsman is a sibling of your friends, you really don't want to ask a question. But let me, out of duty, ask a simple question. First, congratulations, Madam Ombudsman. I think you are doing commendable job. And for the hospital ombudspersons or ombudsmen, I think you're also doing fantastic. I think she did mention my name during her presentation, that I've invested my years in the health sector. So thank you so much. The recommendations that you have on the last slide, I think these are not going to a specific office. These are just in general. And therefore, I wanted to ask you a question on community empowerment. I thought this could also be sitting in your office, whereby civic education on patient rights and the service charter, you could also do better in terms of informing Malawians what are their rights when they are patients and what does the service charter say. I'm saying this because I'm sure the complaints that we are seeing at the hospitals, people need to know of their rights when they're being infringed upon before they seek the care. And I think the previous speaker also did ask, I think it was Loampuzu. I see you've got an IT officer in your office. What are you doing, madam, to ease the logging of complaints? People who are in Zomba City South or indeed in Loampuzu, how easy is it to log complaints without necessarily going to a particular hospital ombudsperson? I'm just thinking electronically to say, how do we make sure that she sees our complaints? I submit, Chair.
Thank you very much, the people of Zomba City South, for bringing out the issues around patients' rights, service charter. I was very much surprised when the Pawem did not touch on these issues, because these are the guys who work very directly with patients. I thought their presentation was going to focus much on the promotion of the patient's rights, how much awareness are they doing to raise these issues, because these patients are subjected to, like paying out of their pockets. Do you raise awareness? Because there are several issues around service charter that you as an organization need to raise with the patients, so that when patients go to the hospital, they should demand the right services from the providers. I didn't hear you speak on that. Thank you that you provided us with information that will be used in that we'll use in future, but you didn't focus much on what you are doing to protect the patients. I think you will speak on that one. Thank you very much. We go to final question from the people of Mangochi West. Or you come...
It's okay, Chair.
Right.
It's that you have spoken my mind. I had a question to Pawema.
Yes.
That do they have some deliberate awareness programs so that the people, rural people, can be aware about their association and what they do and how they can get them if they get victimized within the health services? Just because I'm knowing this association today as a member of parliament, whom I'm a bit exposed than the people I do represent down there. If I'm getting to know them today, what about a person, a rural person in the typical rural in my constituency? How can they know them? Therefore, I want to know if they have some sort of programs which aim to bring awareness of their laws and how patients can get to know them and where they can get them to present their grievances if they have been victimized in our health services. Thank you, Chair.
Thank you very much. Thank you very much. It's very interesting because I know, well, I've interacted with Pawem. They promote, so they, at the entrance of each hospital or the North Board, all these service charters need to be pasted there. I expected them to raise this issue because these are the most important issues for the patients to know their rights. But thank you again that you have raised some important information that we'll use in future. But for now, if you can focus on the state of corruption and health facilities, how much are you collaborating with the patients? Have you interacted with the patients? Have you interfaced? After reading that story, how did you react? What was going through your mind as an organization, that your patients that you are saving and perhaps the patients that you have raised awareness on their rights as patients are being subjected to these corrupt malpractices where they are being coaxed? Sometimes they can be doing that on their own or being coaxed to do that. How much are you doing on that one? But we should not waste much of your time. We hand over to the Office of Ombudsman to address some of the questions raised. We still have some questions that will be coming your way. Thank you very much.
Thank you, Honorable Chairperson, Honorable Members, for the constructive feedback that you have given in the form of questions. In the interest of time, I'm not sure if we may be as exhaustive as we can be in responding to the questions, but very quickly, on the issue of what exactly happened to the Nkota case scenario that I gave, I think I was illustrating how sometimes the complaints are the seemingly small, mundane complaints, that it takes the sitting person at that clinic just going to the pharmacy and saying, Amwene, is this what you have taught this person? The moment there is oversight, this person is like, oh, no, that's not what I said. Actually, here is the prescription. So it is resolved at that level. If it becomes systemic and it is a pattern, then it may be escalated to the Ombudsman. So there are those small things that are dealt with because of the imbalance in power and what we, public officers, sometimes can do when we sit on these chairs to people that are coming to access the services. So that kind of intervention at facility level works. It's like our people have someone who is accompanying them through the system, their advocate right at the facility to avoid those little abuses. So it wasn't escalated. It was dealt with in that manner. But what that means is, if there wasn't the hospital ombudsman, that man would have gone without the medication. If it becomes a pattern, then we'll pick it and address it accordingly. For the specifics, those can be provided of that particular case when we go back to look at was it escalated, to say to the administrator and everything. There was a question about how we can be reached as an office. So in next week, we are submitting to, so far we have submitted to the Office of the Speaker and the Public Appointments Committee our annual report. But next week, we are going to bring it to all the members because we are in the process of gradual printing. It has an entire leaflet in it on how people can access the services of the Ombudsman, including through WhatsApp, through our region offices, even on our Facebook page, on our Twitter, on all manner of social media platforms. But we still know how the digital divide can exclude other people. So we are also working on partnering with local NGOs, in particular NICE, National Initiative for Civic Education. We have an MOU so that people can go in. But the most critical avenue that I talked about is the Mobile Accountability Clinic. Last year, 2025, we were in Chitipa and Palombe. We didn't leave any stone unturned, such that when you're coming from a Mobile Accountability Clinic, you have over 500 complaints because we went to TA by TA. This is what we are. These are your rights. Are you encountering problems? So they register the complaints. So we literally carry this office to the people out there. We are looking to how we can access Likoma this year. In January, we're in Balaka. The other year, we're in Nchinji, Mulanje. We want to go district by district, reaching, particularly the hard-to-reach areas and generating the complaints. So in other words, we have a very holistic approach to ensuring that every Malawian who needs the services of the Ombudsman can access the services through those different means. I'm sure that also speaks to the questions that came up on how we can be accessed. Coordination, this came from Honorable from Zimbabwe Lekezi. Coordination with other entities, yes, there's a great deal of coordination. With Anti-Corruption Bureau, we have bilateral administrative arrangements where once you scrutinize a complaint and you know it is not falling within your jurisdiction, then you then refer. Does this have its own inherent challenges? Yes, it does. And we are working on those so that we become much more coordinated and we have a very effective referral pathway. There was a question on whether we've received any complaints on the investigations that PIAG has done. I would say no complaint has been registered. As I said in my presentation, These are complaints that you do not necessarily expect people to come and report, but the Ombudsman Act gives us power to commence investigations on our own motion if they are in the public interest, which is why when we responded to PIJ, we said, because the health issues are increasingly becoming a huge concern, we will consider commencing an systemic investigation on issues to do with healthcare service delivery. Honorable Chairperson, if the notes that I took are anything to go over, okay, there was the issues raised by Zomba City South, which I think I've addressed on how we do our outreach and the sensitization of people. So a typical mobile accountability clinic would be like the campaign rallies that you have been running. We come there with our goombas. We are not dressed in suits. We get down to the ground and really propagate the message for everyone to hear. We bring the ADCs, we bring the local duty bearers, and they interface with them and ask questions. And then there's the investigations, there's the legal that also do their work. So in the future, with support from development partners, we are thinking that we can have digital kiosks in certain trading centers where people can go in and access toll-free lines to reach us, but also to register their complaints. I think it will work with the decks in the different districts. So we are trying all the efforts to make sure that every little corner, every person in Malawi is reached, but resource constraints, particularly finances, hamper our effectiveness. And I would echo what I said, that this is where the support from Parliament, especially now that we are engaging with your committee, would need to come in. Thank you.
Thank you very much. Pawem?
Thank you, Honorable Chair. I just want to take the role of Pawem in advocacy, because you mentioned about you were anticipating that you should hear more about us advocacy and awareness.
No, but you need to address the questions.
Yes.
Yes.
So we normally incorporate with other partners on World Patients Days. And if you have attended or you have seen for the past few years, Pawem has been one of the leading in the incorporation of the patient rights and advocacy. As a local organization, our capacity to take every concern in all the communities is also a problem because of resources. We operate in districts using district chapters, and our chapters are headed by volunteers who normally call or else get an alarm in the community where they are operating. So a resource problem is one of the factors contributing to that, since we dependently rely on these district chapter representatives who are volunteers. But their role is not diminished or is not limited to report cases or else to advocate for the rights of patients. On patient service charter, we also encourage that in all the facilities that we are in operation, it has to be displayed. If we note that it's not on the wall, we normally advocate that no, it has to be displayed, especially in the OPD departments, whereby every patient or every person visiting the facility can be able to see. So we really know where our gap is, but reaching the whole audience, resources is one of the factors, as evidenced by our friends of Ombudsman. They have said the same. So that's the level of engagement that we are now. Thank you.
Thank you. Thank you very much. Further questions? Mwanza West. Then we go to Nchewu Central East. From Nchewu Central East, we go to Dowa West, in that order.
Thank you, Chair. I'm just interested to know from Pawem, since in your introduction you said you are everywhere and you're the ones who work hand in hand with the patients. Perhaps, is there any hospital that is doing better when it comes to corruption that we can learn from, or should we conclude that every public facility is corrupt? I just want to know.
Thank you very much. We go to Nchewu Central East.
Thank you, Chair, for recognizing the people of Ncheu Central East to ask Pawema a question. In fact, there is an issue in Kiladzu. It says the agents, they do charge patients. For example, in theater, they can charge around 38,000 kwacha. And for maybe mortuary, they can charge 20 to 50,000 kwacha. Did you receive this information? And if you received that information, what did you do? Thank you.
Thank you very much. The people of Ncheu Central East, did you receive such information that patients are subjected to these out-of-pocket payments, and even the dead are being forced to pay the mortuary services? We go to Doha West.
Thank you, Chair, for recognizing the people of Doha West. My question goes to Ombudsman. Can you provide data on how many complaints were sustained versus dismissed? Thank you.
Thank you very much. So just to reinforce the question, you have made your presentation, and we have data here. How many cases were processed? And what were the feedback mechanisms? How much did you go just to, in the process of engaging what would be the offenders or the suspected offenders? But just to also bring to your attention, Ombudsman, so you have said here that the Office of the Hospital Ombudsman reports directly to the Ministry of Health. Actually, it is under Ministry of Health, right? And the recommendation, I know the recommendation, but what should be the takeaway point for this committee? Should we advocate for the, like a commission, a standalone commission, away from the Ministry of Health, where the advertisement will be made and the suitable applicants should apply for the job? A standalone office away from there, just to avoid the conflict of interest. What should be the takeaway point? You need to clarify on that one. Thank you very much. You can take those questions.
Thank you very much, again, for the feedback and the areas where clarity is requested. In terms of the data that we have extracted from the system on all the complaints that we have been handling from 2019, when the Hospital Ombudsman mechanism was launched, to date. I think I did point out there's a graph here, year by year. For example, for the most recent data, which is indicating close to 14,000 cases that went into the system. What we have is the number of cases that were resolved, which is around 10,000. And then the rest, two things, may not necessarily mean they were not resolved, because we have a cutoff point. So by the time of reporting, they are still being addressed. Or some of them will have been referred. Remember, we have said the complex ones are escalated either to medical council and so on and so forth. So that level of detail, through, with your permission, Honorable Chairperson, we can provide when we go back and go case by case of those 10 remaining in the system, to say, did we not take any case up for reasons that we did not have jurisdiction? That information, for purposes of preparing this presentation, we could not get to that level of detail. But it's very good, Honorable, that you have raised that, because we didn't need to provide that complete overview of what is going on with this system. If it takes 14,000 cases, what exactly is going on with each and every one of those cases? The reason why is because when I was opening the presentation, I did say we should see the faces, the people behind these figures. They're not just mere statistics. They are people that are being saved by our hospitals. Or on the key takeaway, Honorable Chairperson, we have a nation that has resource constraints. So as policymakers, when this issue was being touted in 2018, The question was, can we have a sit-alone health service ombudsman? I remember then, because I was in the Human Rights Commission, the prevailing policy by government was not to create any more borders. So that's why for the Gender Equality Commission, instead of having a standalone, they gave it to the Human Rights Commission, as well as the Information Commission. I think for human trafficking in that act, instead of having a human trafficking commission, there's a human trafficking board that sits within the Ministry of Homeland Security. In my own experience, it's very possible to have an institution that is going to be providing oversight sit within a policy holder, provided you guarantee what we call its operational autonomy. People know I have security of tenure in that space. I have my budget. They can manage to transact. Maybe that's in the short term, because I don't think Malawi has resolved the issue of resourcing these entities that we want to be creating. So, can we focus on what we have and what we can work with in the short term? Strengthen what is existing. If you have a system that is able to take, as we are speaking, 22,000 complaints, can we build on that before we throw away this baby along with the bathwater? Let's strengthen what is working, because where are we going to get money in 2026 to say there is the Health Service Commission? But our long-term vision would be, how do we graduate from this thing sitting in the Ministry of Health with the capacitation of the Ombudsman to becoming a full-fledged, and that's a long-term vision. 5 years down the line, 4 years down the line, 3 years down the line. It is why we have provided the South African model, where when you go there, you have an independently recruited person who is their health ombudsman. He has staff, hundreds of staff in their different provinces, working with them because they had the resources. So the key takeaway for the committee would be, where are we? Can we strengthen what is there? Vote here, Minister of Health, it should clearly have a budget line that says hospital ombudsman and its own activities. And probably the question is, the ministry cannot recruit nurses, cannot absorb all the nurses. Do we want to give them the burden of hundreds and hundreds of hospital ombudsmen, or this designation is working? So let's start with where we are at, strengthening what is existing, build on it. In 3, 4, 5 years, we shall see an advert that says government has set up a health ombudsman and they are looking for a healthy ombudsman. So I would say, let's continue this conversation in terms of what do we need short-term, medium-term, long-term, looking at the broader picture, which is we want to safeguard patients' dignity. We want our people to live with human dignity when they go to access healthy services. The way you, Honorable Chairperson, is going to be received at Kamuzu Central Hospital is the same way they should receive someone barefoot and seemingly looking like they are coming from not where you are coming from, so that we cut the elitist divide that we have in the society. Thank you.
Thank you very much, Ombudsman. So we need to advocate for the independent budget allocation for the hospital ombudsman. We also need to advocate for autonomy. That's for the long term, but of course, strengthening the hospital ombudsman capacitation. These are the short term takeaway points that we can, as a committee, run with submissions by the ombudsman. Over to you, the Pawem.
Thank you, Honorable Chair. The first question, as an organization, we recommend Nzuzu Central Hospital, based on their recent activities of installation of CCTV cameras in the pharmacy that has saved a lot of drugs that were being stolen by a pharmacist. We would want in public to recommend Nzuzu Central Hospital for that as one of the facilities that is really doing well in making sure that drug theft, it has to be an issue of history. The other question is about the case of Chiladzu, Honorable. As of now, as of today, we haven't received any case recording that some agents are getting 30,000 or 20,000 or 50,000. But this is an alarm to us. I believe after this meeting, we will make sure that we follow up with the case. Thank you so much.
Thank you very much. Pawem, did you read the article by PIJ and other media organizations? Pay or die. Did you read that article?
No, we didn't. We didn't.
You didn't read that article?
Yes, yes.
All right.
Yeah.
Thank you very much. Questions, members, if any? If not, then let me hand over to the Pawem to make their concluding remarks, then we'll ask the Office of Ombudsman to also share their final remarks.
All right, thank you so much, Honorable Chair, for engaging us as a patient and community welfare organization. We feel like we are honored to represent the patients from the communities that we serve. We understand that we cannot reach to where we are expecting, but we believe that in the long run, we will make sure that we should meet the needs and the demands of Malawians. We know that there are so many cases out there, and very sensitive, very urgent. And as a local organization, we are also fostering in partnership with the CBOs in most of the districts, whereby these cases can also be easily recorded from. So with those few remarks, I would like to thank you so much for your invitation for us to give an insights in this corruption inquiry.
Thank you very much. My clerk here is just reminding me the article was not only published by PIJ, it was a consortium of media organizations. It was also published by Times, Nation, Zodiac, Malawi Institute of Journalism, and other media organizations. Did you have a chance to read that article? The article that exposed corrupt practices in health facilities, like Likoma, Chirazulo, Cholo, KCH, Nzuzu, and other hospitals. Did you read that article?
Yes, if you remember my presentation, there were cases relating to those facilities.
Okay, so that was the article that I was referring to.
All right, thank you so much.
Okay, thank you very much. Over to you, Ombudsman.
Thank you, Honorable Chairperson and Honorable Members. I did already express the gratitude of the Office of the Ombudsman for this level of engagement. Our plea would be that perhaps this doesn't become a one-off collaboration. We might want to explore how the Office of the Ombudsman can engage with your committee, because we run this hospital mechanism, but also because you cannot isolate issues of transparency, accountability, responsiveness from the health sector. So we do wish that, it is our wish that we can continue the engagement beyond this particular inquiry that you're doing. We hope that we have accomplished what you had invited us for, to come and share with you our perspectives on corruption. And I think we've done that from the lens of administrative justice and maladministration. If there's any need for further and better particulars, like Honorable Member had asked, we remain available, because we are a public institution, to keep providing that level. We have provided you with evidence. I think the discourse right now is for evidence-based decision-making, data-driven decision-making. So we would appeal for your support. There's a lot that we can do collaboratively, but also on our own as an independent institution. That should come through the adequate budget support for the office, but also for the hospital ombudsman mechanism. And like we have agreed, let's strengthen what we have in the short term, which is the hospital ombudsman mechanism, because it is serving a purpose, it is adding value. And then in the long term, see how we can build it into a standalone institution, if that is what would be the wishes of the different stakeholders. We remain committed to working collaboratively with the Parliament as a whole, but in particular in this case with the Health Committee. Thank you so much.
Thank you very much, Ombudsman and Pawem, for availing yourself before this committee. We are not taking your presence here for granted. The presentations have been very insightful, the discussions very important. They will inform our next steps as we embark on providing oversight role over the health sector. Would like to also thank the honorable members for being here since morning. We started this conversation or this engagement early in the morning, and for the honourable members to hold on until this hour is something that, as a chair, I need to commend. Just to also inform you that as a committee, we have lined up a number of activities that will also require the collaboration between you as an Office of Ombudsman, but also as Pawem. We are looking forward to working with you on the activities that we have lined up as a committee. The goal is to ensure that we have improved the health service delivery, but also the citizens have access to quality and improved health care services without exposing anyone to financial burden as a principle of universal health coverage. Thank you very much. Once again, behind us, we have refreshments. We invite you to be part of the partakers of the refreshments. Thank you very much, honorable members.
Wasaiwala, subscribe to channel ya AMTV Malawi.